Okay, good evening everyone. So in ICU Uncut series, today we'll be discussing a very important topic which is requested by one of the members on the channel, that how to write the ICU course or the hospital course or discharge summaries or death summaries or case summaries. Means whenever you write a case summary, what all points need to be considered. So the pattern of today's discussion will be in the manner, I will tell them the points which they need to write and they will tell what points they need to elaborate in that particular section. So we'll start. So whenever you write a case summary, it is reflecting that how keenly you have observed the patient, and it is also reflecting how you are communicating the events of that particular patient to anyone who is seeing who will be reading that summary. So it's a reflection of your acumen, your skill which you have performed in the hospital. So make sure you write the crisp and clear points. You need not you don't need to elaborate all the aspects, but you need to point the basic crux of each and every aspect. So the first thing, whenever somebody will read a patient summary, what he wants to know? Identification. That this is so and so, aged male, female, like that. So 25-year-old female or 40-year-old male, obese male, something like that. Yes. So identification should be important. Why it is important? Because certain diseases are important in certain age groups. So first thing you will write, this 24-year-old gentleman or 40-year-old gentleman, age so and so, and obese sort of thing. Secondly, what I follow is there is a question on whether we should write chief complaint earlier or whether we should write known case comorbidities earlier. So what I prefer in ICU and emergencies is, if I know the comorbid conditions of the patient before, then it will help to narrow down the differentials. So suppose a patient comes with high blood sugars and respiratory distress and vomiting and abdominal pain, and if I know that this is a known case of diabetes, uncontrolled diabetes, DK will come into my differentials earlier. So that is a separate issue. So whenever you write a case summary, so first start identification and then known case of so and so thing, known case of diabetic, hypertension. Also in that mention the years, diabetes for so and so years, and for on OHA or insulin dependent or uncontrolled blood pressure, anything. So first thing is identification and comorbidities. Now after you have mentioned the identification, the second point which should come is reason for hospital admission. So what you will write in reason for hospital admission? Anyone?
The chief complaint.
Mike?
The chief complaint.
That is chief complaint. So in chief complaint, how will you write?
The complaint and the duration since he or she has that.
So complaint. It can happen that suppose a patient comes patient was diagnosed with known case of stroke 3-4 days back and now is presenting on the 4th day to hospital. So the chief complaint was not stroke. What has happened now exactly that this patient is came to the hospital? So it can be the patient is aged so and so, had suffered stroke 4 days back, but now his condition or GCS has deteriorated in last 12 hours, and for further evaluation came, or the CT scan has done outside which showed a bleed, now has come for surgical intervention, or the patient was not improving for so and so condition and now came to us, or patient can directly come to us, like that. Something must have happened which has made the patient to search for the help in the hospital. That can be chief complaint, or that can be acute change in certain condition which has made the patient. Sometimes the patient can get DAMA and come to your hospital. Maybe at their center they don't have any intervention facility available, that's why they have come here, or the patient by themselves brought the patient here. So the reason for hospital admission should be clearly mentioned. So somebody is reading should know why this patient has come to our hospital. So identification, such and such patient, then reason for admission. It should include chief complaint plus the current one. It can be either chief complaint if the patient is coming directly, or it can be any deterioration in the clinical acute deterioration in the condition. Now, after that, what should come?
We have to decide patient where in ICU or then we decide to patient admitted under ICU or ward.
How will you decide?
Through the parameters. First of all,
Vitals.
vitals.
The second point, after the patient has come to your emergency or the ICU, the next point will be so and so gentleman or female came to our hospital with complaints of this or acute deterioration in this, and when she was on admission, her or his vitals were, means your vitals plus clinical examination. What were the vitals and what were the clinical examination? Suppose this patient came with a GCS of 7 or 8, came within, there was right sided hemiplegia, or patient is in decay, high blood sugars, and you examine the patient is in shock or something. So after chief complaint, your vitals and clinical examination.
Yes.
Always write on admission, these were the vitals and these were the findings. You don't need to write each and everything like S1, S2 positive, chest was clear and abdomen was positive, important finding, and important negative finding also. Positive finding means this patient has come, GCS was low, there was right sided hemiplegia, or if you can have a cardiac patient, the patient was having chest symptoms for 3-4 days. Now the symptoms have worsened, chest pain has increased, and now the patient has come to our hospital, and on examination the patient has ongoing chest pain.
Yeah.
Or you can say at present the patient is not having any chest pain. So this is a crucial negative finding, and that was a crucial positive finding. And then your clinical examination, you find any cramps or something, or aspiration, or poor oral reflex, or poor gag reflex. So the important positive findings and important negative findings. So on admission, these were the vitals. On clinical examination, these things were positive. And after that, so we have identification, comorbid condition which comes in the identification, then you have the reason for hospital admission, then on admission vitals and clinical examination, and then
we decided where it will be shifted, either ICU or ward.
Before that, you need to also write the provisional diagnosis.
Yes, sir.
What differentials you have made on admission, means this patient came to their hospital and they made a differential, either it can be stroke or meningitis or encephalitis or SOL or
Yes.
anything, you were suspecting any venous sinus thrombosis or anything, or chest pain, pericarditis, aortic. On differential diagnosis, 3-4 things were made. Differential diagnosis of these things were made. It can be acute coronary syndrome, it could be viral myocarditis, something you have made. So these were the differentials, and based on the vitals, the patient was investigation evaluation was planned, what was planned, and patient was shifted to ward, or patient was admitted in the ICU depending on the criteria. So you can write, because the patient was in shock and diagnosis was uncertain, the patient was admitted in ICU for further evaluation, or the patient was hemodynamically stable and now the patient is being admitted into ward for this. So now anybody who will read will get understanding that why this fellow presented to hospital and why we admitted into the ICU or why we admitted into ward. Then if suppose the patient got admitted in the ward or in the ICU, the initial evaluation, if the patient is sick, very sick, suppose the patient is a COPD patient, patient came in respiratory distress, you wrote that this patient is having acute exacerbation of COPD or asthma, the patient was started on nebulization, steroids and BiPAP support and shifted to ICU. In ICU, the nebulization and these were continued and blood gas was done and the PCO2 was this. So BiPAP support was increased and SOS ventilation was planned. Now this was the initial, and investigations were sent. Now if the investigations comes and in between there is no deterioration, that is fine, no need to write that this. So if there is a deterioration in between before the investigation comes, then it needs to be written that by the time investigation comes, patient condition deteriorated and need to ventilate, or some or important investigation which you have done after getting admission. Got my point?
Okay, sir.
Then once the investigations comes, now what is your what are the diagnoses which you have made in the provisional diagnosis? What is your now diagnosis, or how you had narrowed down? Suppose the CT scan is normal, but they say patient is having fever and altered behavior, so CSF, because the CT scan was normal, so CSF was planned.
Okay.
So in the hospital course, in first few 12 hours, you get 12-24 hours, you get an idea that these were the complaints. We made a provisional diagnosis based on these symptoms. We sent the investigation. He was evaluated or investigated, and now the working diagnosis is this, and the patient's treatment was modified. Now two things can happen from here. One thing I forgot to mention, if the patient is getting admitted into the ICU, I have told that if the patient is getting admitted to ICU, you need to write why this patient was getting admitted. We have told them, hai na? So now the important part comes. Now this patient either can improve on this particular course and get shifted to room, or the patient can have a stormy course, the patient can have fluctuating courses, or you have differentials. Now suppose we can take an example of pancreatitis patient. So this is a young boy who presented with acute abdominal pain for 1 day duration. He was having fever for 3-4 days. Now the pain has increased. He has come to the emergency, and now because his respiratory rate was high, he was having was tachypneic, abdominal pain was there, so we get admitted into the ICU. Then in the next 12 to 48 72 hours, we hydrated the patient well, amylase lipase was sent, USG was done, which showed a picture of pancreatitis. Now the hydration was continued. Initially his hemoglobin was this much, 15-16, now which shows hemoconcentration. Now the patient hemoglobin is improved, somewhere around 10-11, urine has improved, but now the patient is little more tachypneic. This is important development. So what are the positive development, what is the negative development? But every day you need to ask why this patient in ICU. So now what is happening now, because the patient is becoming tachypneic, his echo was done or chest x-ray was done, which showed bilateral pleural effusion. Now the patient is on 7th, 8th day. So we are planning a CT scan abdomen to look for the severity or any pseudocyst or infected cyst in the so that's why this is planned. So this is the course. Now if I did a CT scan,
Yes.
how will you write the that report in your case summary? Suppose CT comes and CT comes with a detailed report of 2 paragraphs. How will you write this in case summary?
Sir, we just write at 3-4 days after an
No.
operation.
Suppose we have sent this patient today for CT scan abdomen and the report comes. Now in case summary, when you will prepare, how will you write this 2 pages, 2 paragraphs radiological
So
report?
we put both the points, positive and negative point, then we explain why we CT scan is advised.
Anything, madam? You understood my question?
Yes, sir.
We did a CT scan.
Yes,
We
sir.
mentioned the indication for CT
Yes, sir.
scan. Now the CT scan report comes and they have given 2 paragraph CT scan.
Yes, sir.
So will you write the whole 2 paragraphs in the case summary, or you will write something else?
Sir, only highlighted points will be mentioned, like he is having any complications regarding pancreatitis, whether it is pseudocyst is developing or pleural effusions are there. Only the highlighted points will be described in summary.
Those who are listening is very important. What we have seen in many reports, in many case summaries, my residents also, those who are new journeys, we make this mistake. Whenever they write that the patient CT scan has been done and which showed, in that showed list, they copy paste the whole 2 paragraphs in the case summary. So this disrupts the flow of the summary. So what you need to write is what was specifically mentioned in this specific highlight in that particular case report. Suppose the CT scan showed increase in the size of infarct with midline shift in mass effect. They must have elaborated nicely in the radiological report. So you can always read details in the attached report. If the CT shows there is a necrotizing pancreatitis is there, so CT scan will suggest of necrotizing pancreatitis. So you can always mention in the bracket detailed report attached. So anybody is reading, you need to know what is there in the summary. So now based on those investigations, based on the, we took next decision. We gave this much call to this patient. We get a surgeon call, or we get a neuro call, or we get a cardiac call. Then the opinion was taken on which they advise. Means if you are giving referral or investigation after particular investigation, you need to write the nephro opinion was taken or gastro opinion was taken, and they advised this, and the treatment was modified accordingly. What specific thing they suppose they say nephro says increase the fluid or so now this is the course. So all the milestones, how the patient behaved, they should be mentioned. Most also, if you write that patient was started, suppose the patient is starting having fever, you send culture, so cultures were sent and antibiotics were upgraded. So always try to mention what antibiotics were previously there and what you upgraded. Why this is important? Because this is something which we are trying to implement. We don't routinely follow, but we are trying to implement in our case sheets, so that if this case sheet reaches somewhere else, they get to know what antibiotics we have already given, so they can modify. They don't waste time again by restarting those antibiotics. Or if the patient was responding to those antibiotics, they can continue. Or the patient also knows in next admission what were the antibiotics the patient received. So suppose we have started cefoperazone sulbactam, and now meropenem was started. Suppose we have not given colistin, so it is not mentioned, but now there is an option that colistin can be added. So that's way, whenever antibiotic is upgraded, if culture report comes, also mention the blood by empirically the antibiotics are upgraded, but now the culture report came which showed this organism, and the antibiotics were modified accordingly. This was stopped, this was added. So that's the clinical course. So now from here two things can happen. Either the patient can improve or either the patient can deteriorate. So if there is an improving time, you mention the milestone, the patient gradually improved, and this then on day 4, day 5, the patient get shifted to the room, and there it can continue. If the patient deteriorates, then you need to write the patient deteriorated, or for in view of long-term ventilation, we did a tracheostomy and then gradually wean. Any surgical intervention, you need to mention the reason for that. So by this, the whole course is mentioned. You need to means someone who is reading the summary should get an idea what was happening to this patient. So those who are listening this and those who are new in the ICU, the best exercise is you write a summary and tell to your colleague, read to your colleague. So he or she will ask ki what was it, why this was done, why this was not done. So we suppose you say ki now on the second day we decrease the fluid. So he will ask why the fluid was decreased. So because the echo was done, it was showing ejection fraction of 35%. So this will come in the summary. The echo was done which was showing ejection fraction of 35%. That's why we decreased the fluid. So any deterioration points were there, and then when the patient doesn't improve and deteriorates and has a bradyarrest or something like that, you can mention in the case report. Or if the patient is getting DAMA, then also you need to mention ki this patient is being DAMA, but and patient is on ongoing these medications. Yes. Also I always mention in DAMA we cannot advise, but we can always write this patient is currently on the current medication, on the following medications. And if the patient doesn't make it, and if the patient get expired, then always write the date and time properly. So this pattern should follow. Again, identification of the patient, comorbid condition, what was the reason for hospital position, which includes chief complaint or any deterioration, then your vitals and your clinical judgment, clinical assessment. Based on this, what were your provisional diagnosis and why you decided to keep in ward or why you decided to keep in ICU. Then in ICU, how was the initially treatment was planned and what investigations important you sent. Then based on investigation, how your treatment was modified and now what is your diagnosis. Then the course and important events and important investigations images, then deterioration or improvement sort of things, mentioning the specific things only, then the final event what has happened. So this way you should structure a case summary, and the best thing is write down, say narrate to a friend or narrate to any of your family member who doesn't know anything about case. they will ask why this happened, or means what your friends will help, and this way you will improve. And the beauty of this writing case summary is, once you start writing good case summaries, it makes you see the patient more and more in detail. Until unless you have seen the patient in detail, you won't be able to write a good case summary, and it reflects your clinical acumen. It will improve your clinical acumen.
Yes.
So, any questions from your side?